Bismillahirrahmanirrahim. Let's start our class today. Today lecture is for psychiatry, and it is a kind of a bit different than the medicine approach. So that's why it will take us a bit longer to learn the approach, because we have already learned the medicine approach. It is a bit different because it's more related to talking, and it is the midway between counseling and medical approach. So we have to keep into our mind that we are going to do the counseling station as well as the medical station. So that thing should be in our mind uh, when we are starting like thinking about the psychiatry, because it is the midway between medical approach and the counseling approach. So the patient centered approach will be like it will be our priority. Okay, so starting from the today we will be discussing, because I wanted to teach you more stations. However, it took me very long because the approach is quite different. Yeah, laptop is back here. Which one? Laptop. Okay. The first thing we are going to discuss is the depression approach, because it is the most common question. It's coming from the depression. So depression, regarding the depression approach, the thing should be in your mind. That's always we do the mistake regarding these station, is that then when we start asking questions and after that we get to know that it is the depression, and then we forget about the what was the patient concern, because in our mind is the depression and we want to tell about the depression. This is the most common error which student like make while dealing with a patient with a depression. For example, how the depression person will be presenting to you, it will be coming like, I'm not feeling well. Okay, simple. I'm not feeling well. I'm tired. I'm losing weight. I can't sleep. I'm feeling low. Any of these symptoms can be depression. However, you can see that all of these symptoms are related to many other diseases. So we can make no guess that it is depression until we will follow our approach and we will have the clue. Then we will come to know that it is the depression. So never be hurry. Never try to learn from the stations like it is the depression. Never assume before. Always go with your approach. So we are going to discuss regarding the approach. Uh, Again, the first question: what's since all believe feeling that any of these symptoms can come with the depression, and you will be asking again the open-ended question, and then you will be doing the tupa. And one is regarding the tupa is S, because I have a patient says I'm feeling low. So you need to rate the, as we score the pain, S for score. Our other mnemonic is the for the pain is Stupa KRS, S for score. Here you will be asking the same question as you have been asking for the pain. Can you score your mood for me? Like 1 is the lowest mood and 10 is the highest mood. But keep in mind, in regarding the pain, I want you to make the difference, because in the pain score, just a wait. Yeah, here, the more the score is, the mood is good. In the pain, the more the score of the pain is, the score is not fine. So this should be in your mind. But you will be asking the same question like you will be asking regarding the pain, and that would be, can you score your mood for me? And okay, when you will be like asking, you will start asking all these questions. Sorry, I was like putting my charger on. Okay, so this is the general approach. How you have to approach a patient with depression. Okay, so then whenever you will have some clue, because we start asking our DD. Then, for example, if you have a clue per patient in the start says that, okay, how this has happened. Patient in the start says that, actually, doc, I was divorced like 3 months before, and after that I start having this symptom, because you are doing onset how your symptoms started, and patient may open at that point. If it is not open, we will be asking still these questions again. Hello? Can you listen me? Okay. Okay, then whenever you find any clue regarding any of these symptoms, for example, any of these symptoms, for example, you are doing the tupa of any of these symptoms, then you will be asking certain questions. Whenever you have a clue, then you will be exploring the depression. How will you explore the depression? First of all, you need to ask the rule-in question. What are the rule-in question for the depression? If there are two core symptoms, always remember these should be like in your bones. It should be so much engraved with your language. You can ask this question like quite easily, because first thing is, during the last month, how have you been feeling? Have you bothered to feeling low? Ask simple question. Even you can ask, have you been feeling low for the last month? Okay, or hopeless. You need to ask one question. One is this question. Second question, lack of interest. These two questions. You can ask very simple question. How have been your mood for the last 1 month? The other question is, do you have little interest or pleasure in doing activities? These are the two core questions of the. For example, the patient is saying negative for these. You are not going to ask more questions. Okay, because these are ABCD of depression. You need to ask these questions. Okay, this is not to grade the. Keep in mind, first of all, we need to diagnose the depression. If it is there or not. If it is there, how much is there? Why? We generally do not ask these kind of questions, how much is there? But here we need to evaluate, because in UK system, it is the GP who is managing depression. So there are 3 levels of depression. We are going to discuss it because you are the person who need to manage the depression. With certain exception, we are going to discuss as well. Okay. So after you have asked these 2 questions, one mood, another anhedonia, you have ruled this, and patient say, yes, I'm little interest. Okay. Then you are going to ask all of these minor symptoms, because they are present or not. Still, the patient has these 2, the patient is going to have depression. You ask a lot of these questions, all of these questions, patient is saying some positive, some negative, patient is still going to have the depression. So that should be in mind. All of these questions regarding the depression, any depression scenario, you need to ask all of these questions, and in a very, very quick way. For example, how is your energy? Are you tired in these days? For example, the patient present with the tiredness. You're not asking these questions. The patient present with the sleeping problem. You're not going to ask the sleeping problem. However, any of these questions, the patient present with one of these symptoms, you're going to ask all of these questions. Have you lost your appetite? Have you lost or gained your weight? Why gain? Because sometimes there is an atypical depression where the patient starts like gaining the weight. Similarly, it's not only the patient say, I can't sleep well. Patient can say, I'm oversleeping. Then still it is the depression. That's the atypical depression. Okay. So you need to ask both of these questions in 2 ends. One, like losing or gaining weight, and other is like sleeping problem. Patient can open up to you like, yes, I am sleeping very little nowadays. And then you are going to ask more questions. Tell me more about that. Okay. Then inappropriate gait, lack of concentration, diminished ability to think, agitation, all of these questions. Maybe in the exam, real exam, all of these questions are not coming in your mind. No problem. Don't worry. But never forget to ask these 2 questions. So this is the clue. You just remember all of these questions. It's possible. You're not asking all of these questions. You can ask very simple questions out of them, but never forget to ask these 2 questions, because they are ABCD of depression. Never forget. Okay. Then what is the rule out? This is just we ruled in, but we cannot assume we have ruled in and this is depression. We're going to ask the bipolar question. Patient can have the low mood, but still he can have the bipolar disorder, like elevated symptom as well, along with the depression. That's the bipolar disorder. You need to ask the hypothyroidism. It's a very common. Patient can present with hypothyroidism and depression as well. So you need to exclude the hypothyroidism. Then post-traumatic stress disorder, seasonal affective disorder, and postnatal depression. And for the postnatal depression, there should be a woman. You're not going to ask this question to a man, of course. And obviously, you are going to it should be a childbearing age. If the female, like 70-year-old, and you are asking the question, have you delivered a baby recently? Anything like that, this will look like a foolish. These are the foolishes which, like, most of the time, that's the cause of the failure. We are not going to comment, do any foolish in the exam. So we are a doctor. We are going to ask the straight question which we ask to our patients. Okay. Okay, these are the questions I have put in front of you, like bipolar disorder, hypothyroidism. You are going to give a read to them, quick read to them, and you can make your own questions regarding that, because this is not important. I encourage the people who are making their own dictionary, because they are going to get more scoring in their exam. They are not using my dictionary, or they are not using any other dictionary. They have their own style. Always encourage, and you will be quite easy while asking your own style questions, because you have made that, because these are your own questions. Always, we just put by so that you can compare which type of question you are going to ask. Okay, post-traumatic stress disorder. Never forget. Whenever you are ruling out post-traumatic stress disorder, the flashback. The word flashback should be like you should say the word flashback. Why? Do you have any traumatic, embarrassing event? Okay, patient can say yes. My wife, for example, I got divorced 2 months ago. Is that a post-traumatic stress disorder? Yeah. Do you have any traumatic, embarrassing situation? Yeah. Yes, actually, I was on a fleet, and 2 of the person due to accident died. So this is not a post-traumatic stress disorder. This is an event that is on your conscious and making you feel bad, and that's causing you depression. But for the post-traumatic stress disorder, always flashback. Ask about the flashback and nightmare. Flashback and nightmare, these 2 words. So this should be in your conscious. Then the seasonal affective disorder, you know about it. It's quite easy to ask about. Okay, postnatal, then it is the postnatal depression. All of these questions, just give a read to them. And when you need to ask only the woman with the childbearing age, you ask, by any chance, have you given birth to a baby? She said, yes. Okay, well, for the last 1 month. Yes, you can ask all of these questions. Why? Because postnatal depression is occurring like in 4 weeks. It's 4 weeks to 6 weeks time. It can occur anytime even after that. Okay, then a new window will open, and we are going to discuss. There's a scenario in that we will be discussing that, and what is the postnatal what are the blues, what are the postnatal stress, and what is the postnatal psychosis. We're discussing that. Okay, then comes, I'm giving more time on the approach, because 5 scenarios, 5 scenarios we are going to discuss with the same approach with a little bit difference. That's why I'm like taking your time on the development of the approach, because it is quite important. Now, risk of, what are the risks? We are asking these questions. Okay, here, why I have highlighted SSAOLI. Why not other? Because this is red, because these areas are more important here. Of course, we are going to ask all of these questions, but in a quick way. Is this the first time you are having this? Like, you are going to ask, are you suffering from any long-term medical condition? Don't say that which condition. It can be any chronic medical condition, taking any medication, because any medication can cause these low moods or anything like that. You didn't need to take. But when you are going to reach DSSA, Tolly, and this point, this is the risk factor. Stress, sleep, smoking, alcohol. You need to ask all of these questions. Even recreational drug. Never forget to ask recreational drug, because sometimes people are taking recreational drugs, and that is causing them the depression. And you forget to ask. Never forget to ask. Then ask about the relationship, and the relationship history is very, very much important. I have put all of these things here: sleep, stress, alcohol, drug, sex, occupational relation, because the occupation is quite important. You never know, the patient is working. Actually, I will say a very, very important word for this: socioeconomic history. In these scenarios, socioeconomic history is important. We always ask, what do you do for a living? Okay, this is the socioeconomic history, but here we need to explore more. How to explore more? For example, you will be asking the question, okay, what do you do for a living? How you are managing your finances. Is there any problem with managing your finances? Okay, you need to ask all these questions in a very explorative way. Is there anybody else at your home who is helping you in this? Take the social history. Who do you live with? We always ask who do you live with, but here you need to explore more. Okay, who do you live with? I live alone. So that's, do you have friends? So do you meet with your friends? So who do you live with? You need to explore it more like relationship. Okay, so you need to ask all of these questions. Then there comes these questions should be in your mind whenever you are dealing with whenever by taking the medical history, you say that it is the depression. Okay, this window should be open in your mind. Make a memory out of it, like that it should be open in front of you, and you will be asking all of these questions. How your sexual relationship, and how is, like, people are having erectile dysfunction and they are coming with a depression, and you are not asked any because of your especially we the Asian are not habitual of asking such kind of questions. So in this scenario, you will be asking these kind of questions, okay? Because if the person is having erectile dysfunction and you're not asking anything, he may be say, actually, doc, is that necessary to tell you? So offer the confidentiality. How to offer the confidentiality? You know that the scenario Dr. Adil has taught you regarding that, like offer the confidentiality. If in this scenario, if the patient comes, we are going to discuss in some other day the sexual scenario in a separate way, but you need to explore this in this scenario as well, okay? Then comes the red flags. So if you have not explored the red flag in this scenario, you are failed. Trust me, I can say with the surety that in the depression scenario, you have not explored the red flag. Any of these you can forget, and they are going to deduct the marks. But if you're not asked about the red flags in this scenario, you're failed. Why? Because you need to be safe, doctor. Because the patient can have I'm low mood, and you're not asked about the have you ever thought of hurting yourself or hurting anybody else? You can ask single-ended question, but important is first ask, have you ever thought of hurting yourself? Patient say, yeah. Then the window is open. You need to ask a lot of questions regarding that. Like what I say, manji dana. Whenever the patient says anything regarding the red flag, ask a lot of questions. Don't think that my time is like going, because you need to explore this by any chance, okay? Then if yes, high risk or low risk, you need to stratify. And how you can stratify? You need to ask a lot of questions. There come the scenario we'll be discussing in that scenario with question. And then ask about the hallucination. Do you hear voices? Is any part of your body is dead? Ask these two questions is sufficient. It's sufficient. Then if you say yes, then we need to ask more questions. And what are those questions? We are going to discuss in the schizophrenia scenario, okay? Then ice. Here it is ice, two ice. Ice, two ice. Why? Idea. Do you know what's going on with you? The second thing is, what are your main queries? This is the question we took from the medicine. There are two more questions. However, we ask this question in PMA, Holy Family Dysautonomy impact, but never forget to ask this question, how is affecting your life? How it is affecting your life? And coping, how you are coping with it. Might be patient is taking some drugs, patient has made some own plan, and you are not exploring that. How you are coping with it? So always ask these two questions in these scenarios. Nothing else. Observation, OET, you need to complete the OET, because you cannot assume that I'm not going to take any observation. I need just say in a very precise way, I need to take the observation. Don't say what observation. Just say in this scenario, I need to take your observation. Do your thyroid and systemic examination. Always say thyroid examination, because if for example, the patient is tired, the patient is having low mood, especially you need to say that, okay? Then you need to do all these tests, full account, electrolyte, and all that, just to say it. Then use the E protocol. The E protocol, I'm sorry, it should have been before the OET. The E protocol should have been here when the patient say that it's impacting my life. Actually, it is disturbing a lot of my life. I cannot work. Why I am asking this question? This question you can never forget, impact on life. Why? How you are going to stratify the mood. The patient say, okay, you have established that it is the depression, but how you are going to stratify then which type of depression? There are 3 levels of depression. One is mild, moderate, and severe. And without asking this question, you cannot do. anything. Say, yes, it's impacting my life. How? Ask how. Because he need to explain. Because if it is impacting his daily life activities too much, it is severe depression. If it is doing a little bit, then it is the moderate one. Okay, then it is, he can do activity but with some difficulty, then it is the moderate one. So the treatment is different. So we are going to discuss in the treatment option why it is different. We are going to discuss there. Okay, but never forget to ask impact in the depression scenario, even in all of the psychiatry scenario. Okay, so e-protocol, you have already I think that Dr. Adil have given you the class. It is the first of all, accept emotion, validate emotions, and empathy. I can see this has affected you. I can see after you have asked about the impact on your life and what you're doing for the coping. So it comes like you need to sympathize the patient. How we sympathize the patient? Like with the E protocol. What is E protocol? Accept the emotion, validate the emotion, and empathize the response. How will you say these 3 sentences? Just mug that in your mind. Okay, I can see you. I can see this has affected you. I understand that. The second word is understand that. 3, I'm sorry. Okay, so just go through that. And this line, I can see, I can understand, I'm sorry. You need to learn this by heart. This is going to help you a lot, because I cannot say to the patient, I am empathizing with you. We need certain phrases, certain sentences to say at once whenever we feel like it's appropriate. For that, we need to learn these phrases, and this should be in our reflexes. Okay. Now comes toward the management. Before going to the management, we are just going through the classification of depression, because without that you cannot manage the patient. Mild, moderate, severe. So what is the mild? Few symptom. Few symptoms, like it can be one of the major symptoms, other can be 2, 3 the minor symptoms. However, there should be no functional impairment, or minor, very minor, not exactly minor. Mild to moderate functional impairment with marked symptoms. Don't worry about that. If you have misdiagnosed, you can say like mild. From mild you have diagnosed that moderate. Don't be panicked. So there is no clear window between mild to moderate and moderate to severe. If you say to severe, moderate, and moderate, you say severe, no problem at all, because you have diagnosed that and you are given the treatment for that. It's fine. Okay. So these are what are their like treatment options. This has been cut from here, because this is all, because I was working on this. This is all treatment for this as well. Okay, number one is it is all treatment for this as well. For the mild, what is do the lifestyle modification? These are the all lifestyle modification, because do moderate exercise, persuade the hobbies, meet up with friends, talking through your feeling that can help you. Talking through your feelings that can help you. That is like you can advise some yoga and anything like that. You can give your reading books. This is all lifestyle modification. But after giving them the lifestyle modification, the treatment for the mild is CBT. It is you who is going to treat. Never do I'm going to refer you. All of these treatment you are going to do. Okay. So there are certain exceptions. We're going to discuss that exception as well. It is you have done the lifestyle modification, then CBT therapy. You will say you need talking therapy. For need, I'm going to refer you to a psychologist. Okay. I'm going to don't say like I'm going to refer. Better to say I'm going to like make an appointment with a psychologist. Book an appointment with a psychologist. Okay. Then the self-help group is important here. You need to. I'm still talking about the mild depression, because it's the same. Only no medical treatment is required. Other things are same. Okay. CBT, self-help group. There are self-help groups. There are certain sites you can go. You can enroll with them. People are like engaging with themselves, with other people, and they are working on it. Lifestyle modification, I have already talked about. These are the lifestyle modifications. And additionally, apart from these lifestyle modifications, because this is the typographical error, I'm going to correct that after taking the class, because there is some typographical. If the person is smoking, you need to ask to like quit smoking. If the person is drinking, ask about the AA group. All with alcohol scenario, we are going to discuss over there how we are going to deal with the alcohol scenarios. If there is any socioeconomic consideration, help them. How with the refer to the social services. Offer all. Never forget to offer crisis card. There are different number written on it. If you feel low suicidal thoughts, you can call them. And this is the safety netting as well. Safety netting and crisis card is the same. And ask them that if you feel low, very low, or you feel harming yourself, just call at 999. Say that. This is the safety netting. Okay, this is for the mild depression. However, everything will stay the same except in the mild, moderate to severe depression, we are going to prescribe the antidepressant. Which antidepressant? Mostly we prescribe the SSRIs, citalopram, fluoxetine. You need to take this medication on the regular basis. It will take 2 to 3 weeks to start working. However, you can feel better on the 4th week. And you need to take this not less than 6 months. Okay, this you need to say to the patient because this is important. If one is asking and not. Okay, and always counsel about the sexual dysfunctionality because all of these causes sexual dysfunction like erectile dysfunction, low libido in female in the male. This is a very common side effect. You need to learn about that and you need to tell the patient regarding this. Okay. Note, if the depression is severe, not responding to the treatment, or there are hallucination, refer to psychiatrist. This is exception. There are other exceptions. These are the exceptions when we need to refer to the patient. Where this depends upon the patient's symptom. Patient psychotic symptoms, we are going to refer immediately. Hallucination, suicidal ideation, immediately. Immediately means now, right now. Resistant to treatment, you need to this is not now referral, but it is again the referral to the psychiatrist. Postnatal depression, you are not going to deal with the postnatal depression. You are not going to refer this patient as well. Cannot figure whether the depression or not, still you need to refer. Okay, these are the exception when you need to refer. Okay. So we have learned about the approach regarding dealing with the depression. So this is more like you are talking, this is more you have to focus on the social, economics, and personal things. This is more related to that thing. Anything that comes, then you need to learn in a very quick way because the depression scenarios are quite long. You need to ask a lot of questions in that, and you need to apply the E protocol. You need to empathize the patient. So you cannot repeat even a single question in this scenario. Okay. So this is the first scenario we're going to this low mood. FY2 in the GP, 37-year-old lady presented to you with some concern. Talk to the patient. Patient, your husband asked you to see the doctor because your mood is low. You feel very low for the last 4 months. Daughter died 3 months ago. They can change that. So you need to learn how to go with your approach. She will also tell you that her daughter start going in the nursery. You have lost interest in everything, shopping, but never had the suicidal ideation. You are a housewife. Your relationship with your husband has been good and mood is this. All of these questions you need to ask. We will be starting with our approach. Which approach? Low mood, she says, is low mood. So we need to two pass all S, tupa and S, tupa and S. Okay. And whenever in this scenario, what is the important thing where you people can do a blunder? Patient say, okay, you ask, is there any, how did your symptoms start? Is there any particular event that has happened? Yes, my daughter died and she was very young, 3 months ago. And you are not empathizing. You are not using E protocol. You're not empathizing. This is the thing. This can really, this could be a disaster if you do this. So what you need to do, you need to be very empathetic. I'm really sorry to hear about that. And you must be in a very difficult situation. I can see that. So use the E protocol even, and Okay. Then you will be asking simple question regarding all these questions we have already talked about. Red flag, you will be ruling out and nothing changed. We have already discussed. And you will find that the patient is having mild depression because she has lost the interest, but she's doing the daily activities. She is participating. Loss of interest, but she's participating and she's doing her work. Whatever his work is, she's doing. So this could be the mild depression. So what you need to do is you need to give all the treatment we have talked about. What you need to, like, lifestyle modification. In this lifestyle modification are different. Engaging her in healthy activities is her lifestyle modification. You need to, like, CBT. You can never forget about the CBT and never say CBT. You will say talking therapy. For that, I can make an appointment for you with the psychologist. It's not psychiatrist, it's the psychologist. Okay. And then you will be offering in then the crisis card, and you will be telling the self-help group. You will be asking her to engage. In this, you will be asking all, and this is the simplest scenario. The simple most scenario in this lineage is this. Okay. And you will be offering the leaflet, and after 2 weeks, you will be doing the follow-up. Okay. The next is the depression follow-up. Ever doing the GP surgery, come for the follow-up. She had presented last week with tiredness and had blood test. Everything is normal. And in this scenario, what we need to do is we need to go with the 4 Qs, start with the 4 Qs, simple 4 Qs. After that, okay, tiredness, and then you will be going to do you will be doing tiredness. You will be, for the tiredness, you will be doing all the TUPA boy, because you don't know yet that it is depression. You need to stick with your approach. You will be doing TUPA. After that, patient will give some clue. Any other problem? Yes, I have sleep problem. And never rush to say that, okay, because this is the concern. Look at the approach. I want to show you one thing. It is very important. What I taught you, depression and concern. The patient concern is I'm tired and sleeping problem. So you cannot ignore the sleeping problem. She's having sleeping problem. So what do you need to ask? Explore the sleeping problem. First question for the sleeping problem is what? What type of sleeping problem? You have problem with falling to sleep, or when you are sleeping, you get up early. You say, yeah. Meanwhile, she say, I have a trouble in falling asleep. Then you need to ask her the question. You get up early up in the morning, say, because this is also a symptom of depression. When the patient is going late to bed, early to rise, that means it is a symptom of depression, because the person with depression used to get very early in the morning. Okay. And they have the trouble going to sleep. Okay. So no, don't assume that it is the depression. Ask single question. Okay. She say, yeah, I have problem in sleeping. Ask about the sleep hygiene. Never forget. This was the scenario which was in my exam. This was the scenario in my exam. So ask about the sleeping in a very detailed way, because you later on you need to manage it. If you have not asked about, tell me about your sleep. Do you watch TV? Or because I have not, today we are not going to discuss the sleep issue. The insomnia is the other scenario. Other day we are going to discuss. However, I'm telling you, you need to explore the insomnia as well. Tiredness, insomnia, then you will get to know that the patient will say energy is very low. When the patient is saying energy is very low, you need to ask all of questions regarding the mood. Then you will be doing, after doing all that, because whenever I say rule in question, it is opening of one window. We cannot say where we have to rule in question. We are asking the ruling out question, and there comes a positive window. Then we will be starting doing ruling in question. For example, patient say, my mood is low. You need to ask all of the question for the low mood. You need to ask 2 pass, S, even score. You need to score the mood for me. And then you will minor and major symptom of depression. That's it. And after that, she will be saying that she has recently lost her job, because this is like impairing of her work. This is like comparing impact. When you will be asking impact, yes, doc, it's impacting my life badly because I lost my job because I don't want to work. So this is impacting your life. So this is which depression it is. Which depression it is? Anybody? Now, which depression it is? I think everybody's sleeping. Yeah, it is moderate. It's moderate. Okay, say, okay, then nothing, no difference will be, you will be asking the same question first, and this scenario, only two things are not the same. One, you will be asking 4 questions, 4 Qs. For what? Because she's on a follow-up visit. You will be asking 4 questions. Second thing, it is the moderate one, so treatment will be different. The third thing, you have already done all these tests and then came to be normal. You are not going to ask that, I'm going to do this investigation again. You are not going to ask. If you say that, that will deduct your marks. Okay? Yeah, it is moderate. Exactly, this is moderate. So similarly, you will be, we have talked about the management because I have not written all the management here. The management is there. This is for the moderate and severe is the same. Everything will be staying the same. You will be putting her on medication, SSRIs, okay? And you will counsel all the counseling you need to do. Then there is another depression follow-up scenario. Patient, 40-year-old man follow-up referred to the psychiatrist 2 months ago with low mood. This is a bit different because the patient will be the resistant here. This is a challenging scenario. The other one, 2 are not challenging. This is a bit challenging. I tell you why it is challenging. Consultant diagnosed with the mild depression, started on CBT. Mild is what? CBT. So talk to the patient and address her concern. Everything in this scenario is the same. Like the consultant has diagnosed with mild, the patient now can turn out into a moderate one because CBT is useless. It is not helping me. The patient could be angry. My consultant has asked me this and this is not working. I have nothing changed in my life. I'm still feeling the same. That he might be shouting at you. I don't know. Like he can be like sometimes calm, sometimes very shouting. They change the responses and your response should be accordingly. Whenever the patient is shouting on you, stay calm like this. Like nodding your head. Don't say anything. You need not to say, okay. Don't say, just after start, like when he like left shouting or he's calm, then you start your talk, okay? My energies is very low, difficult to cope with work, mood is 2 out of 10. You will be asking all of these questions because you need not to explore very a lot because the patient is already on the follow-up and everything is like already diagnosed. So, but you will be doing the DD, but in a very quick way. However, you need to ask, look at this scenario. You have not asked about what are your main queries. You have not done the eyes and the patient will not say you. And you have not addressed her concern. Concern is that I am worried. Okay. Actually, when you start addressing her concern, addressing his concern, he will say, I don't want to lose interest in the sex because somebody told me, or it decreases the libido. So you need to address this question as well. He says because the depression it itself causes low libido. So the patient, whenever you ask about what's bothering you, he might say, actually, I have lost interest in sex. That's bothering me. Okay. So this thing should be in your mind. So this is a bit difficult, challenging scenario. Why it is challenging? One, already the psychiatrist has made the diagnosis and it comes in your mind that what I'm going to do. The psychiatrist has can do nothing. What I'm going to do. Don't think like that. You can do. Okay. Second thing, the patient is saying, what is the treatment? SSRI. You are already, the person is already telling that I'm having low libido, I'm losing interest in sex, and you are going to prescribe that medication to the person who's having certain, this is making this scenario very difficult. So we are going to deal with it. Okay, let's ask about the previous visit, 4 questions, similar approach. We are asking about, obviously we are going to do all these very quick way because we will not engage anywhere else and we are going to do the PMA Holy Family Desert and ask all these questions, ask about the relation and everything we have already talked about. Then you need to do the OET. After doing the OET, but with the management, based on you have told me that you had the moderate depression. So along with the other thing, you need to ask what you are doing. She's taking like CBD. The other thing she had told, maybe the psychiatrist has told to be compliance, ask about the compliance, because asking about the compliance is very much necessary in such kind of questions, because if you are not explored the compliance is not only with the medication, compliance is the lifestyle modification, compliance is with like what they have told you, and in that is going to explore, you need to explore more. Okay, so because here you need, because the treatment is the same, if the patient is taking already the same thing you are going to do, you need to continue all those advices. Along with that, I'm going to prescribe you your medication. Your concern is quite genuine. These medication can cause sexual dysfunction or low libido. However, we need, it is quite important for you, for that reboxetine is the medication which has lesser effect. Okay, you can continue taking this medication, reboxetine, just remember that. So other questions are the same. We have already talked about that, how to take these medication. No, there is another question, that is severe depression in a young man. Why it is severe? Because it is having the try to harm himself. Otherwise, the things are the same. There's a difference, because the other scenario after this is coming the self-harm scenario, but it is not a self-harm scenario. The patient only had the ideation of self-harming, only have the ideation, not he has already done. Okay. He has been collecting paracetamol tablets. 1 month ago, he had thought of self-harming. Okay. So ask all of these questions in a similar way. Low mood is with the low mood. You need to ask all of the PAS, PAS, scoring, and ask all these questions. Rule in question for depression, then rule out questions for all of these disorders, then red flag. When you will say red flag, the patient going to open to you. In the red flag, there are two types of questions. One are the for suicidal, other is for the hallucination. In general, we ask only 1 or 2 questions for them, not more than that. But when the patient say yes, then you need to explore more. Say yes, okay, yes, I have 1 month ago, I thought that harming myself. Okay, can you please tell me more about that? Doc, what do you want to know? Yes, I want to know that how this idea came in your mind. What made you to think that? Was there any particular event, and what you did that? Did you any planning for that? You need to ask all of these questions. Like, have you seen any thought again by any chance? Any thought again came for that? Okay, by any chance this thought can come in future? Is some, okay, asking all these questions, you need to ask somebody is accompanying you. You need to ask this, somebody is accompanying you, because you are going to send, and because this is the severe with suicidal ideation. Severe you can manage by yourself, but it is severe with suicidal ideation. With suicidal ideation is immediate refer. Okay, so you need to ask this, and asking after this management is based on your symptoms. You have the severe depression and suicidal ideation. Mention that suicidal ideation, because only the severe depression is not the indication for referral. Depression, like giving what is depression, and you need immediate referral, because here you need to add what? Suicidal ideation. Okay, the patient might be saying, no, I'm accompanying, I can go myself. Never let the patient go himself. Okay, I'll say, okay, I'm going to arrange an ambulance for you, and they can take you there. Okay, if the patient says somebody is accompanying me, then you can send the patient. This patient you can send with that person, because he had the suicidal ideation. Okay, not he has done that. Patient say, I can drive myself. It is advisable not to drive, as it's not safe for you and for others as well, because the patient in the severe depression, not only because of suicidal ideation, the patient cannot drive. You need to like send somebody along the patient who can take patient to the hospital. If the patient has an dependent of a social service, because you need to like take the patient like away from home, because you have already asked in the history, dependence and all that, relation, social history, and now you need to ask the patient, like we offer the patient some social services, and always I need to inform the crisis resolution. What is crisis resolution home team? It is basically a team, because in the other, where you are sending the patient, they are going to take care of the patient. So always say crisis team. Only say crisis team. Don't complex it. Don't make it complex. Like say the resolution crisis team. Okay. Then the other scenario is postnatal depression. Everything is same. The patient has non-urgent patient to see you. Address all concern. Give 5 weeks ago. Give birth to 5 weeks ago. So here we need to know about the blues. Blue is only like fewer symptom, and it is after 2 to 3 days, and it is most of the time in the first week and never after 2 weeks. Okay, this is the blue. And postnatal depression can be between first 2 weeks. However, it can go up to the 6 weeks. That is the postnatal depression. And if the patient, you asking about the harming yourself and harming baby, then it is always the psychosis, postnatal psychosis. Okay, so you need to ask these questions. You need to actually differentiate between psychosis and postnatal depression, because these are the two different entities. However, you aren't going to refer both of them, but you need to explore them. Okay, depression, postnatal blues. This has written resolved within 5 days, or it can prolong after 2 weeks, but mostly it is. And postnatal psychosis, do you thought of harming your baby? Do you have feeling that your baby is evil? So actually you need to explore this. If this is there, so, and you are in the hospital, you need to separate the baby. Okay, this is important. But there's no scenario with this, but you need to know about that. You need to ask. If you're not asking this question to this is quite important, because you cannot differentiate the postnatal depression from the postnatal psychosis. Only this question will differentiate. Okay, so because you need to differentiate this, then you will be asking all the other questions. Here, the two most important, two more things are important. One is the pregnancy and birth history. Always ask about the pregnancy history. How was your pregnancy? Ask about that, and how you have been like feeling during your pregnancy. Any problem with your pregnancy? Okay. Then ask about the birth history, how the baby was delivered. Ask about at term, post term. Take the birth history. Then the relationship history. This is again very much important. Is the baby was like wanted baby or unwanted baby? Like how is your relationship? Like who is the father of your child? Are you living with him? Ask all of these questions in this scenario, because this is important. Because only the other thing is the only depression approach. The only question important are the postnatal psychosis question, pregnancy, birth, and relationship history. That's it. Other things are the same. And in this way, you are going to refer this patient postnatal depression. You are not going to treat the patient, and you are going to make an urgent referral to a psychiatrist. That's it. And here the mother having the problem involve any problem with taking care of her baby, involve the social services regarding that. Then safety netting, you are offering the crisis card and follow up in 2 weeks. If this is also safety netting, if not like met, you need to say this, the safety netting as well. Yes, you can ask this question as well. If you can ask, but we cannot go. For example, patients say, no, I'm okay. Psychosis, history of psychosis. Why you need to take the history of psychosis? If the patient, if there is any risk factor, the patient say yes, she's now having the psychosis. Why you need to ask the? We will not complicate it in that way. Okay, now the next question is self-harm approach. Okay, in the self-harm approach, this is kind of depression. It is extreme of the depression. It can be different, but like I'm telling you, because we always ask this question to there. In the self-harm approach, the keep two things in your mind. Always in this thing. medical and psychological treatment. Medical and psychological treatment. People sometimes forget the medical treatment, sometimes forget the psychological treatment. For example, the patient had cut his wrist. Okay, we need to, like, this is an emergency. We need to deal with that first. Okay. For example, patient had taken the overdose of anything. So that is a medical emergency. So we need to take care of the medical emergency first, then the other emergency. So in the treatment, always the medical emergency first. Always in self-harm patient, the medical emergency first. Never forget about that. Sometimes, because we have read this in the psychiatry scenario, we only focus on the psychological thing. We forget about the medical thing. Even we're not asking about the medical thing. Okay. So here comes the self-harm approach. There are, you need to, in this way, as we go with the stroke, before, during, after. Fall approach is the same approach before. But question will be obviously the different. Was there any precipitant? First of all, if the self-harm approach, first question you need to ask is, describe me the event. You need to ask, what has happened? The patient will be saying that event, okay, this has happened, this was the reason. And after saying that, if the patient has not told you a lot, you will be asking the before question. What was the precipitant? Would you like to tell me about what has happened? Was that planned or impulsive? This is important because the impulsive act is not that bad as the planned is. Did you carry out the final act like writing any note? Okay. Have you terminated any contract? This is any action they have taken, like they have taken any contract, they are writing any note. You need to ask these kind of questions. Like any, any precautions taken against discovery? You close your curtains, you locked your door, and don't need to ask all of these questions, but you can ask a couple of them. Were you alone at home? Did you wait anybody to leave the home? These are the before question. Now during, how did you harm yourself? How did you? Okay. What's going through your mind at the time? Was your attention like to like harming yourself or just to draw attention? Did you think this is like to kill you? What did you do straight after your self-harm? What did you do? Like he called somebody. These are the all questions you need to ask to the patient. You need to learn all of these questions. Maybe some of them will skip from your mind, but you will have the idea what I did need to ask before, during, and after. Did you call anybody? Did you get to emergency? Who find you? Like, how did you feel when help arrived? How did you feel about the attempt? Now, do you regret? This is like, you need to ask about the regret, because this is quite important. You need to ask about the regret or guilt. Ask about the current mood, still feeling any suicidal thought. If you feel any, by any chance, would you do that in the future? What might prevent you in the future if this has happened? What can prevent you? Are you willing to accept the treatment? What is the meaning of life for you? These are the all questions you need to ask. You need to learn all of these questions, because in the suicidal history, these questions are quite important for you, before, during, and after. Okay. If it is the dose, then this is all the psychological questions. Now we comes towards the medical questions. If the overdose, which medication, how did you get it? You get it like graded or at once, because you know that if it is the staggered dose of paracetamol, that is more dangerous than that once dose. How much medication you took? You took with what? You need to ask complete history of that medication and what you did after that you take it. Sometimes maybe patient has done something like self-vomiting, but you need to ask that. You may to decide to take the medication. Okay, this is the same question. You need to ask 3-4 questions regarding if the cutting, you need to ask about these cutting questions as well. Okay, so here comes the self-harm. There are two scenarios we are going to discuss here. One is 16-year-old pregnant took the overdose of paracetamol. Last night, cut her wrist and cut her wrist in the morning. Look at this. This is the one scenario that is coming. This is very important scenario. Cutting up her wrist and overdose. So you need to explore both of them. So she has been in the emergency. Doctor who declare fit and discharge access the patient. So we need not to go behind the medical treatment because it's already been done. Because it is in the prompt. Because this is a very long scenario. They know you. So you cannot like do all that. Okay. So in this, you need to explore all the questions. First of all, the event. What has happened? Why? What is the motive? Actually, you need to explore the motive in a very deep before, during, after. Done. If no questions are coming in your mind, just go before, during, and after. Okay. After asking all of these questions, this is another scenario. This is the same approach we are going to discuss. FY2 in ER, the patient-year-old took some overdose of medication. Assess the patient, discuss initial management with the patient. This is the separate, because that is going to be discharged, and this is the coming toward the different scenario, because here the medical treatment is the mainstay of treatment. There is no medical treatment. Only you need to refer, like you need to make an appointment with the psychiatrist, because the medical treatment has already been given. So you need to the psychological treatment. Here the medical treatment is the prime important. Okay, 16 tablet 2 hours ago, and you don't have any problem with at the moment. What happened? But you told your mother that you are gay, and she like infuriated at you. And this is the separate scenario. The other was the pregnancy scenario. What was the motive behind? Because we can see, because you thought you were pregnant and want to get rid of pregnancy, as the period was 1 week. You told your boyfriend, who is 16-year-old, who could be pregnant, but he acted angrily. That is the motive behind. So you need to explore the motive, and then here you will be asking, in this scenario, you will be asking questions regarding a life partner as well. Because whenever there is a concern, never forget to explore that concern, how your relationship with your partner, and talk about, have you talked to your parents about that, and all that protocol you need to explore this kind of scenario. Okay. So this is the GRAPE self-harm overdose approach. Do the risk assessment during, after, before. This is in the both of them. In the both of them, you are going to do that. Then ask a specific question, the type of method. Again, this is in the both of these scenario. Why I'm like making this scenario together? Because you can compare by yourself that what is the difference. So then you need to ask about the, never forget to ask the questions regarding the depression, because depression is one of the patient might have, is the one of the major risk factor for suicide. Okay. So always in the suicidal scenario, ask the depression question, maybe not a lot, but you can ask a little bit questions of depression. Then you need to ask about the DD. Then you need to ask the PMA, Holy Family Desert. Never forget to ask, because there are risk factor in those. Okay. So all of these questions which are important for you to ask, you are going to ask here again. Any drug abuse and all these questions, and you need to take the okay. Here comes the two different scenarios. So we are going to, for example, let's suppose it is the first scenario in which you are going to discharge the patient. So our concern is not the medical treatment. Our concern is the social concern. So explore all that social concern and risk. And the patient say, if the patient say, yeah, I can do that again, I don't feel guilty. So what you need to do is, you cannot discharge the patient. But the patient here will say, I'm feeling guilty. So you are going to discharge the patient, and you are going to do all the safety netting. You are encourage the patient like to involve in the healthy activity. You are like doing all that. You are going to give the crisis card, like you feel low, and you are going to do all that except for the medical treatment. Here in the second scenario, what you are going to do is, you are going to say, but these are the questions we have already talked about, because these are the same questions in the PMA, Holy Family Desert. These are the same questions written over there. You can do by yourself. Then after doing that, in the first scenario, you are going to do the pregnancy. Never forget to do the pregnancy test. Don't assume that she's pregnant. You need to do by yourself. In the first scenario in which the person is pregnant and she has done cut his wrist and taken the overdose, and you need to do the pregnancy test as well. And then you need to, after, because you have done the management, you need to do the psychiatric evaluation as well. You require psychiatric evaluation for the patient. In the second, this is the treatment for the second. We need to admit you because you need to give your decision. You need to admit you and explain to the patient that, because you have already asked about when you took, she said 2 hours ago. Okay, you will say, okay, we will wait for 2 hours more to take your blood test for paracetamol. If it comes above the normal level, then we will be giving you an acetylcysteine through your veins, okay? But you will need to admit this patient, okay? Whatever the cause is, you need to admit this patient, okay? Then this will be given over the 12 hours. After the completion of the treatment, we will be doing your blood tests again. And then this is the medical treatment. We have done already the medical treatment. This is the psychiatric treatment. After we have done that, I'm going to refer for the psychiatric assessment. Okay? Because you have already done the psychiatric assessment, but the self-harm, it is there. So you need to involve the psychiatric department. Okay? It is the patient concerned. He's asking, can cause the harm. Tell that it can never say, don't worry, it is not causing the harm. It can cause the harm. However, we will be taking care of you. We will be like looking after you. That's why we are keeping you under observation. Okay, so this is the question the patient can ask. This is all about the self-harm scenario. You need to explore during, before, because the other things are almost same in the depression and self-harm scenario. You need to explore all that. Specific questions are root cause, exploring the root cause, and for that we can ask open-ended question, but what should be in your mind during, before, during, and after. And regarding the treatment, they think there should be 2 things in our mind. One is the medical treatment, the other is the psychological considerations. Okay, so don't forget about there are 2 scenarios, one in which medical treatment is quite important. In another scenario, the psychological considerations are quite important. Okay, but it is all about the history taking. And how it is the history taking during, after, during, before, during, and after. Never forget about that. Okay, just learn these questions by heart. Then comes the last approach, that is the schizophrenia approach. It is a bit easy approach because the depression and honestly speaking, depression and self-harm approach is a bit different, and it is a bit challenging. But I find this schizophrenia approach quite like easy. First of all, there are 2 scenarios we have put here. Explore the event. First thing, like similarly, self-harm, explore the event. What here? Explore the event. How you will explore the event? Patient comes and say, doc, actually, police is after me. Please save me. Can say anything. Explore the event. Okay, could you please tell me more about that? Patient's doc, I think my sister-in-law going to kill me. You need to, okay, I can see you are quite worried. Sorry that you've been feeling in that way. Can you please tell me more about that? And along with that, offer your sympathy, like patience, like behave with the patient in the way the patient should be open to you. He feels safe with you. He's not, look here. This patient is not in his conscious. What should be in your mind? The other patient we have dealt with, all of them are in their conscious. This patient, his conscious is conscientious or conscious is not normal because he's schizophrenic. His thought processing is impaired. The other thought processing is not impaired. The other thing is their thought process is okay, but they are suffering with some disease. Okay. Here the problem is his thought process is not working. So we need a different kind of approach. So Doc, are you spy as well? So what do you need to do here? You need to simply offer confidentiality. No, I'm your doctor. keep in mind, whatever you and me will be talking here will be staying between us and our team. Nobody is going to learn about that. Don't worry about that. So this is the way you need to deal with this patient. This is the clue. And in the start, you need to offer some confidentiality, then the patient will be open to you. Okay, doc, actually, I feel that somebody's after me. Schizophrenia. Okay. So this is how need to explore the event. Then C. The first questions are regarding the C. Like patient can say, somebody is behind me. I can see. Patient is seeing, watching something. To ask about everything regarding C. How long have you been seeing that? What they want? Do you speak to them? Do you see them? Like you need to explore that his delusional thought or hallucination. This is a delusional thought. You need to explore that in every aspect. Do they talk to you, speak, or they speak amongst themselves? Because all of these questions, patient might say one of them, actually, the police is after me. You other thing he will not have in his conscience. You need to ask. Don't assume that patient is going to tell you all that. They want you to ask these questions to the patient. Okay. What do they want from you? What do they ask you to do? Always ask all of these questions. If you don't do that, what they are asking, what they're going to do with you. Ask all of these questions. These are the delusional thought questions. Okay. Then voices. Do you hear voices? This is the hallucination. Actually, because this is some typographical error. Actually, here is the delusion. Here it is like a hallucination. And then it is the thought. There are three things you need to explore. One is, after exploring the event, you need delusional thoughts. One, delusions. Second, hallucination. It can, you see anything, like you hear anything. And the last thing is thought problem. Do you feel that somebody can steal your thought? Somebody is inserting thought in your mind. Do you think that whatever you are thinking, people can like know about that? It's the thought broadcasting. Thought insertion, thought broadcasting, thought stealing. These three questions are enough. Okay. Just give me a minute. Hello. 10 minutes more. I'm in a class. Okay. FY police brought 24-year-old in the hospital. He wants to hand himself to the police, but the police found nothing wrong with him. Assess and discuss the management with the patient. You've been asking all of these questions. Patient is going to answer all of these questions to you, and you will get to know. This is quite easy question. Okay. Body language, patient is looking over your shoulder, here and there, anxious, withdrawn, like he's in paranoid situation. This is the paranoid thing. Okay. You will ask you during the consult, will you, where is the police? Are you with the police? This is the question I was asking. Where is the police? Where is the police? Are you with the police? Here you need to offer the confidentiality. No, of course, no, I'm your doctor and you have come to the right place. Okay, keep in mind, whatever we'll be talking here, it will be staying between you and me and our team. Nobody going to know about that. No police, nobody. So offer your confidentiality, okay? Other is the same is the schizophrenia scenario. FY2 in the GP. This is A&E, this is GP. There's a difference. Here you are going to admit the patient, and here you are going to like refer the patient, okay? Ask you to see by his mother. Mother's called the surgery 2 hours ago, complained of the son was behaving strangely, speaking to one of his colleagues on the phone, and was advised to have a face-to-face consultation. Okay, this is the mother is calling. If the mother is calling, what you need to do is, again, the protocol, you need to offer the protocol of the telephone call, confirm the relationship, confirm the address, confirm the patient. Then you need to offer, like, if the call gets, okay, then offer, can you bring the patient here so that, okay, then you will be start asking questions. Okay, if this is so, or if the patient is there, he has booked, then you will be asking direct face-to-face consultation. Don't worry about that. They can do that, but you should be prepared for that. If it's the telephonic consultation, okay, it is the telephonic consultation. Okay. The patient in the, you feel a lot of spies are behind you. This is all again the same thought. You need to ask all of these questions. You just give or read to this, and nothing is like different. It is all about the schizophrenic patient, because here the spies are around. They are like behind you, and similarly you need to ask all of these questions. Yeah, they are not going. The gist behind this scenario is that you need to learn, ask all of these questions. Thought question, hallucination question, delusion question. Delusion question or more, you need to ask all of the delusional questions. Okay. So approach, what will be the approach? Then you will paraphrase. I understand that you have been brought by the police. Can you tell me what has happened? What you are doing here? Exploring the event. Okay. How did you get with the police? Okay. Then you will be asking all of these questions, like we have already talked about. These are the questions we have already talked about. Then you will be asking about like broadcasting, thought insertion, thought withdrawal, the same question, the same 4 domains we are going to explore. I'm saying again and again. Then you will not assume, you will ask 1 or 2 questions. How have been your mood? Not very much. Don't go deep into this, like depression or you cannot ask these questions. Sorry, we need to skip this. You need to, both of these should be skipped, because the patient conscious is not working, and you need to ask. However, if her mother is talking, then you can ask this question. If this is the direct patient, his conscious is not working properly, and you're asking this question, this is a blunder. So we are not going to commit any blunder, because the patient, we are not going to ask, do you feel cold, other feel normal, because this is not the for. If the mother is talking, you can ask all of the PSD. If then any event has happened, you can ask this question to the mother. Red flag. Here, the red flag are 2. Have you ever thought of hurting yourself, or have you ever thought of hurting others? Because the schizophrenic patients are dangerous for others as well. So this is the safety netting as well. This is red flag. The only red flag is not have you thought of hurting yourself. The red flag is as well, have you thought, because here it is more important. Have you ever thought of hurting others? Ask more question as well. Okay, like have you thought of hurting yourself? Have you ever did that? Okay. Then you can ask these questions to the mother. If the mother is talking, you can ask all of these questions. How is his sleep? How is stress level in life? You can ask all of these questions. And similarly, because there are 2 scenarios we are dealing. One is the person himself. The other is the mother. So we cannot ask a lot of questions, which are the normal, understandable questions to the patient who is himself talking. But if the mother is talking, you can ask all of these questions. So this is a difference between these 2 scenarios. So anything else is for idea and concern, impact and copying. And this is only you need to done when the mother, and if the patient, you need not to ask. Yes, the idea you are going to ask, do you have any idea what's going on? Yeah, I have an idea, because the police is after me. They are thinking that I'm a criminal. I know what's going on. So again, the delusional thoughts are coming. So, but you need to ask. Then based on what you have told me, I believe that you may be having the call schizophrenia. Then explain that what is schizophrenia. So what you need to do is you need to get it admitted. If the patient says, I don't want to get admitted, this is quite important. The important clue in the schizophrenia scenario, it is, I'm reiterating, you are going to ask that you need to get admitted. The patient says, no, you cannot contain me. This is against my rights. You cannot contain me. I'm going. So still you cannot let the patient go. You are going to tell, okay, I'm sorry to tell you for that. I need to call to the crisis team, and they are going to come and they're going to manage you, because in such situation, it can be dangerous for you and can be dangerous for the other person. If the patient say, okay, I can go with, I can go myself. Don't allow him to go. You will say, I am going to like book an ambulance for you. I'm going to send a person with you. We are going to send you in the psychiatric emergency. Okay. Where who is going to treat you? There is a multidisciplinary team who is going to treat you with on the psychologist, psychiatrist, mental health nurse, social worker, and support worker. This team is going to work with you. Okay. If the patient says, yes, you can send me, the patient show goodness to you, then what you're going to say, okay, I'm going to pass the information to crisis team. That's it. This is all. This is all for today. Any question you want to ask? Because I know that this is a bit difficult. I tried to make it easy for you because there are 3 approaches. They are in the similar fashion because we are like going from the depression, we have read like augmenting the severity. Then we have reached towards suicidal ideation. Then we have reached towards the suicidal act. Then the last one is schizophrenia. Like the first scenarios were harming himself. The second, schizophrenic is harming others. So the danger is they can harm others. So any like question you want to ask? It was a bit different approach, so I had to work a lot on this because it's quite different. So among themselves, they are different. Even in the medical approach, we follow the same approach. However, in the next, we are going to end, in my next lecture, psychiatry will going to be end. The next will be fine. It will not be like this because the other in which we are going to like cage approach, that is for the alcoholics, and only the difference is for the alcoholics and drug addicts. And we are going to like study for the insomnia. We are going, other one is that eating disorders. We are going to discuss with them. But I'm going to see if there is any other. We are going to end that in the next rough session. Any question? The student is today sent for today because okay. Clara, do you have any question, any query regarding that, or like Zainab, you, Asma, anybody? I want you to like because we are like ending this phase almost in the coming week. We are going to end our session. That's why I want to encourage you guys to ask a lot of questions so that your concept should be quite clear. But we can arrange data for you. We can like work together, but keep in mind, it is you. You should have a belief in you. Like if you are going to have a confidence in yourself, then this exam is not difficult. Trust me, this exam is not difficult exam. I don't know why people says that this is a difficult exam for making money or what, but this is not a difficult exam. This is a different exam. Just, I would say this is a different exam because all the exam we have already taken is some similar. One have taken the PLAB-1, one has taken the MLE, one has taken like the part 1, any exam. They are the different, similar exam. You take your books and you start studying, and this is a different exam. Only confidence not coming, sir. Okay, what is the reason? Why confidence is not coming? So we can talk on that. Let me